Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. Participant microphones have been muted for this webinar. However, we do encourage you to use the chat box to interact with the presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. It is now my pleasure to introduce our moderator for today, from the Johns Hopkins Bloomberg School of Public Health, Professor Len Rubenstein. Welcome, Professor Len.
Thank you, Ryan. Good morning, good afternoon, good evening, everyone. We are going to discuss today the issue of violence and of violence against healthcare in the context of COVID. And I would like to just give you a little overview of the context and share with you some background. And we know that violence against healthcare in conflict seems to know no end. Just 2 weeks ago, the Safeguarding Health in Conflict Coalition issued a report on violence against healthcare in conflict in 2019 in 20 countries. We found more than 1,200 such incidents, and the violence was committed by state forces, by non-state armed groups, and they had different targets, motives, and used different kinds of weapons. But the results were that at least 150 health workers were killed while doing their jobs, and more than 200 health facilities were damaged or destroyed. Shortly after the COVID-19 pandemic emerged, we began to see attacks and threats against health workers and facilities involved in the response, and sometimes attacks on patients as well. Governments have punished health workers for speaking the truth about the epidemic. Security forces have employed intimidation, arrest, or inflicted violence to enforce public health measures. Gangs and ad hoc, sometimes relying on disinformation or political agendas, have attacked health workers in hospitals. Armed groups have obstructed the response or conducted their own activities in a way that violence is taking place across the world in at least 65 countries. But in humanitarian settings, the concerns are especially concerning because of the vulnerability of the populations. So even less spectacular forms of interference must be addressed. And so we need to explore what is happening and what might be done. We're very fortunate to have a great lineup of speakers today. We'll begin with Christina Villa, who's the director of Insecurity Insight, an NGO dedicated to data collection and analysis of threats facing people living and working in dangerous environments. Currently, Insecurity Insight is monitoring violence affecting healthcare, violence against healthcare, both in armed conflict and in the COVID-19 response. And we'll hear from Christina about the data she has collected. And I'm pleased to collaborate with Christina in a consortium on research on the impact of attacks on healthcare based at the University of Manchester. Our next speaker will be Dr. Christian Mulamba, a physician who has been with the International Medical Corps since 2006, and since 2016 has been the country director in the Central African Republic, overseeing emergency medical services, healthcare training, and development programs. Christian has also been involved with the International Medical Corps' post-Ebola response in Sierra Leone, Liberia, Guinea-Conakry, and Mali, and also has overseen projects in Nigeria, Chad, and Cameroon. Our final speaker will be Khalid Fahim, who is Program Director for the Swedish Committee of Afghanistan, overseeing programs in education, health, disability, and rural development programs. He also oversees cross-cutting integration of gender and human rights and civil society initiatives across 14 provinces. Khalid has been working in the development sector for more than 15 years and has worked with the World Food Program. So we'll have our speakers first, and then you can, as Ryan said, put your questions in the chat box, and we should have time for questions. So I'll turn it over to Christina for our first presentation.
Thank you, Len, and good morning or good afternoon, everyone, depending on where you are. I've been asked to say a few words of how the COVID-19 pandemic has affected and changed the patterns of violence or threats of violence against healthcare providers. Now, the COVID-19 crisis has changed so many aspects of our lives that we considered normal. And yet, whenever there have been underlying problems, they did not go away because of the pandemic or during the pandemic. I think these two observations are also very much what is going on in relation to how the pandemic has affected the patterns of violence against healthcare. As Len already mentioned in his introductions, there are far too many conflict-related effects on healthcare in many countries. As he said, for 2019, over 1,000 such events were recorded. And this underlying problem has not gone away. Yet what we are seeing in the context of the pandemic is that we are facing an additional threat, or health workers rather facing this threat, which comes from community members who respond with violence or threats of violence to the actual health measures that are implemented to address the pandemic. And that, in a way, is the new normal we are seeing around the pandemic in relation to patterns of violence against healthcare. I've prepared a little graph that sort of gives you an idea of what's going on. So I'll try to share that with you. And so in the hope that you can all see this, this graph explains a little bit of what has been going on this year. In yellow, you see the events that Insecurity Insight has logged for the Safeguarding Health in Conflict Coalition of violence against healthcare providers in the context of conflict, and they're defined by the fact that they are perpetrated by people who are part of a conflict party. Now, the year started as the previous year had ended, but then the pandemic was declared. And suddenly, we see this drop in reported events to as few as 4 per week, or these blocks always show a sort of a week of recorded events. Now, I don't know why that is, and this is part of a general problem we all face when we look at the issue of violence against healthcare, because the perpetrators never tell us why they do it, or in this case, why they don't do it. To get to this important question of why it is happening at all, we always have to make informed assumption of what is probably going on. So I think what probably went on at that time is that the conflict actors who use violence that affects healthcare as part of their strategic conflict activities were perhaps as taken aback by the sudden changes to the world as we knew it, as you and I probably were. And they may have reconsidered their strategies and ways of operating. And why they did that somewhat caused what they normally did. But it seems that the unfortunate decision after quite a short period of time was, among many of these conflict actors, that it was in their interest to continue pursuing their strategic activities that affected healthcare, pandemic or not. And this occurred despite the call by the UN Secretary General for a global ceasefire. So unfortunately, the pandemic has not stopped the conflict-related violence. We continue to see bombing of quarantine centers in Yemen, destruction of hospitals in Libya that are treating COVID-19 patients, health workers on their way to work to discuss of how to protect patients in rehabilitation centers in Libya were killed. An ambulance driver transporting test kits in Myanmar was killed in crossfire. These events that have happened for a very long time and that an underlying problem of our world continue. Yet, we're also seeing what we might refer to as the new normal of the COVID-19 pandemic. And that's shown in this graph here in the big blocks in red. And these are events that we have logged that are qualitatively different from the yellow ones, in that the perpetrator is not linked to a conflict party. The perpetrator are people from the community. They're in a way like you and me. And these events also directly target health activities that have some connection to the COVID-19 response. We've seen assaults on health workers when they asked for testing to be carried out. Health workers have been attacked when people escaped from quarantine centers. Health workers may have come to harm by security forces as they try to go to work, as security forces try to enforce lockdowns. And we have also seen some very tragic, horrific events of health workers being attacked by community members because they feared that the health workers would spread the virus because of their close contact with patients. And these events have, for example, occurred during a burial of a doctor who had died himself of COVID-19. So these are the new kind of events that in many respects have changed the way people who look at attacks on healthcare have to look at it in the pandemic, because we're suddenly seeing a very different kind of perpetrator. Now, obviously, this kind of violence by community members has always happened, and we know it has always happened. But what is new is the scale of it, because the events you see here logged in this graph are the ones that we've identified from open sources in media and to some extent social media. And we all know that the events reported in such sources are only a fraction of what happens. They're the tip of the iceberg. So the fact that we suddenly see so many events reported, in my view, really is an indication that something really has changed and that we're seeing new forms of violence against health workers. So that, I think, is the worrying trend. I will now conclude with a few thoughts of why this really matters, why we all need to think about, and also how this links to the wider humanitarian response in areas of high needs. So first of all, and I think as we probably will also hear later in the seminar, violence against healthcare has a devastating impact on any kind of healthcare provision. And this also then clearly affects the ability to respond to the COVID-19 pandemic, as well as treating any other diseases or providing primary healthcare. Secondly, health workers tend to be people who've chosen their profession because they like to care for others. And it is extremely difficult for such people to suddenly find themselves at the receiving end of violence. And that has a huge impact on health workers' mental health, their ability to continue working, and therefore also really impacts on the healthcare that can be delivered where such violence is widespread. And finally, I fear that there may also be much wider patterns emerging of how this violence against healthcare affects the wider humanitarian response. I think we're all aware that the virus did not spread as fast in some of the most vulnerable areas in the world as we may have initially expected. And I think one of the reasons is that there are just not as many planes landing as in London and New York who could bring people who are already affected with the virus. But what has also happened is that the first people who tested positive in some of these most vulnerable settings were actually aid workers and peacekeepers. This was the case in South Sudan and Mali. And this, to me, is a very worrying development, because it means that it shifts the whole perspective of the humanitarian sector, because suddenly they are not just there to help, but they are also a real threat who can bring the virus. And we're seeing this playing out in what we may refer to as an anti-foreigner sentiment in many places. And we know of reported attacks on aid workers being called Corona Go Home or similar. And this also plays out in social media in many places and many other spaces. So I think the overall issue we really need to watch here and think about is how this trend of violence against health providers is also going to play out in these most vulnerable communities that are dependent on aid. And I think we may in the future see a mixture of very complex patterns of fear, frustration, anger, and many other aspects. And I'm very glad that so many of you are here today to take this issue seriously and to be part of that community who thinks of what can be done to address this really important issue, that we get the pandemic under control, and that most of all, the people in humanitarian settings who have very high needs also receive the care they deserve and desperately need. So thank you very much, and I look forward to your comments and the discussions later. Over, back to you, Len.
Thank you, Christina. That was really enlightening. And I think the last point you made about the connection between the potential or the reality of health workers, humanitarian aid workers, being seen as the vector of the virus kind of adds another very troubling dimension to this, in a way that's a good segue to Christian, where some of these issues have arisen in the Central African Republic. Before turning to Christian, though, I just want to remind people that if you have questions, just post them in the chat box, and we will get to them after our speakers. So Christian, the floor is yours.
Thank you, Dr. Len, and good afternoon and good morning, everybody. In line to what Christine presented, most of the issues can be shared with the context in Central African Republic. But first of all, the specificity in CAR is that since 7 years, the country is ongoing a very complex humanitarian crisis, which is man-made disaster with several armed groups that are in place, and a context in which violence is very familiar, and healthcare, unfortunately, has been victim of those armed groups in many occasions. Between 2017 to 2019, only in IMC catchment area, we had 6 health facilities vandalized. For some of them in several times, even though rehabilitation was conducted, but they were again vandalized. And 3 healthcare workers perished during that time. One was working with International Medical Corps, and 2 others were MOH affiliated personnel. In a context where we know Central African Republic has been one of the very forgotten when it's come to funding humanitarian crisis. Mobilizing resources for properly supporting and developing the healthcare system here has been a challenge. The humanitarian coordinator voicing herself with other NGOs often go on frontline for advocating for resources in CAR. And it's very difficult to see in that context when resources are highly mobilized, healthcare will be vandalized after all the effort made by the UN agencies, by NGOs, and by the government. But regardless of the distraction ongoing, we see also a lot of resilience for the community themselves to continue rebuilding whatever has been destroyed or vandalized, and we continue assisting them in that effort. The time of the COVID, we see a complexity of things here in Central African Republic, especially at this very moment as the country is preparing for the next election of the current president is going through a new election in December, and the population seems to have a very mixed appreciation of the effort he has done to stabilize the country. Some will say not much was done to stop the violence. Some will say there were a lot of improvements. In the middle of it, we have the UN peacekeeping operation, one of the biggest in Africa, struggling to impose peace in the entire Central African Republic territory. Now, that's in Bangui especially raised attention, where we see people mobilizing already for the electoral campaign, and any action by the government is always perceived with an idea behind, like the benefit of any action done either by humanitarian community, the UN agencies, will benefit the current regime to present as an achievement during the government ruling of CR, and therefore claim those benefits for the next election, maybe for more voting. That, unfortunately, is predisposing, give a situation where most of the population are in a kind of opposition mode. Whatever word will come from the government will be taken as the government preparing for the election. And unfortunately, the Ministry of Health, not being separated from the government, is facing challenges to pass the message on COVID. Now, as healthcare workers, we know that we don't have time to go through all those debates, and we have to work. Team deploy on the terrain to do the work, sensitizing on COVID and the prevention message, will face the resistance. Whenever supply have to be distributed, people will resist and saying this has been given by the government or for the benefit of the government, or the Ministry of Health is behind of it for getting money, and all this creating every single day challenge for healthcare workers to perform their activities. There is also the conspiracy theory that's ongoing around COVID. Some saying it's an imported disease, some saying they want to use it for vaccinating Africa. And the debate will go on and on and on the social media, and unfortunately affecting people with limited level of education, and can lead to violence, as we have seen. A couple of donations were gracefully given by foreign country helping CR to fight COVID, but on the social media that was portrayed like a vaccine has been introduced in CR for start vaccinating as an experiment, Central African, and we don't want that. And we warn anyone who will be going through this path that there will be some repercussion. And every day, people have to justify whatever action they will do, whatever donation they will do, to avoid that misinterpretation done on the terrain. At an extent that the use of the social media. We see it as a tool that can benefit the humanitarian community, but the entire population, by passing positive messages and correct information so that the population become the first actor in COVID prevention. But we see a lot of negative messaging as well through social media, with a conspiracy theory which is going and growing every single day, which unfortunately seems to meet population expectation of opposing to the government during next elections. Putting this together to create a toxic melting pot, which at the end of the day end up becoming very stressful for the healthcare workers. But hopefully we didn't see anyone dying because of COVID work, but the maximum we got, people got beaten, slapped, but mostly it's insults and threat, sometimes restriction to get into some neighborhood, but not yet, no physical violence with severe consequences. In the CAR, NGOs have grouped together to try as much as we can compile every single incident happening, to locate where the incident is happening, so that we could share the information among us to avoid being exposed, but also pass the message from what we see, and the trained to the government and anybody working on risk communication and community engagement so that the message gets recalibrated to cool down the moods and get healthcare workers protected. One of the major things we agreed on before starting intense COVID response in CAR was to ensure that risk communication and community engagement is done by Central African to Central African, a peer-to-peer communication instead of NGOs branded communication to Central African that will raise more opposition, as we were sensing from the beginning, the conspiracy theory taking a lot of space in the social media, but also within the community here as we're moving. My question will be, or a reflection will be, how can we better use the social media and how can we control negative messaging on social media during this pandemic period for the benefit of healthcare workers, but the entire community. Thank you for your time, and I'll be welcoming any question. Over.
Thank you, Christian. That was very illuminating, and these are kinds of problems that we certainly didn't anticipate and add to what you've been dealing with over these many years. Let me turn it over now to Khalid in Kabul about the situation with violence in Afghanistan and particularly around COVID.
Thank you very much, Professor Len, and good morning and good afternoon to everybody, depending on where you are. Swedish Committee for Afghanistan has been working in Afghanistan since for 40 years in different programmatic sectors, one of them being health program. When it comes to the violence against health workers, as many of you might be aware that the context in Afghanistan is characterized by conflict, and the parties to the conflict in Afghanistan are Taliban and the NATO and US-backed government of Afghanistan. So there is a conflict ongoing in many parts of the country, challenging and constraining not only health services delivery, but all the development and humanitarian response to the communities. The year 2019 and 2020 so far was a challenging year, and 2020 has also been a challenging year in terms of violence against health workers and health facilities. United Nations Assistance Mission for Afghanistan in 2019 documented 75 incidents impacting healthcare during 2019. In those, the nature of the incidents are either forced closure of health facilities, destruction of clinics by either intentional targeting of the health facilities or collateral damage to the health facilities, abduction of the health staff, intimidation of the health personnel, and all those 75 incidents that had been registered against health service delivery that had resulted in loss of 24,000 hours of healthcare delivery for the population of Afghanistan. And among these incidents, unfortunately, also 13 health personnel were killed due to that violence. 34 were reported injured and 35 have been abducted. by the parties involved in conflict. And also in 2020, from March 11, when COVID was declared as pandemic, to 23rd May, 15 additional attacks against health have been registered by UN assistance mission. That out of these 15 attacks, 10 has been identified and attributed to Taliban. 3 of them has been attributed to the Afghan National Security Forces, while 1 of them has so far remained unattributed, and that was that sad incident or attack on the maternity hospital in Kabul that was supported by MSF. So no one has claimed the responsibility for that one. This has been, so it means despite the COVID outbreak in Afghanistan, unfortunately, the violence has continued and the health workers in health facilities have sustained damages due to the conflict. Swedish Committee for Afghanistan had registered only 68 incidents in 2019. And these 68 incidents are not only related to SCA Health Services. SCA also operates in education, rural development, and rehabilitation of Afghans with disabilities. So these 68 incidents, also the nature differs from abductions, to health and schools destruction, either collaterally damaged or directly attacked, and our personnel, our aid workers, frontline workers intimidated. These are the kinds of instances. I would like to a little bit go in detail to one of the incidents that happened to one of the health facilities supported by Swedish Committee in Wardak province of Afghanistan. And that was that one of the health facilities in Tangi Saidan, Daimirdad district, that was raided by the Afghan National Security Forces. The Afghan National Security Forces enter the health facility. They interrogate and intimidate the staff, and they shot one patient attendant dead inside the health facility. Then they take 4 others, including 2 health facility staff, outside the health facility and take them with themselves. The next morning, the dead bodies of the 2 health facility staff and 1 other associated to be the Taliban district civilian health representative, health focal point. Their dead bodies were found in 50 meters to the health facility, while the head of clinic was detained and taken by the Afghan National Security Forces, and after 2 months he was released. And inside the health facility, they also intimidated and searched all the health facility and also injured 2 women inpatients in the health facilities that they were admitted into the health facility. And that has that incident has affected the local population's trust on the independence of the health facilities, and it has dramatically decreased the women and children who were coming to seek health services in that health facility. And in response to that incident, the Taliban also reacted to that one and forced closure of 42 health facilities supported by Swedish Committee in that province. That meant that on daily basis, 5,600 population of the Wardak province had lost access to essential health services. And those 42 health facilities remain closed from 13. The attack on the health facility happened on 8 June, while on 13 June, Taliban closed the health facilities up to 20 July. While Swedish committee, with its longer-term presence in Afghanistan and closely working with the communities were mobilized, and they negotiated the reopening of the health facilities, and the health facilities were reopened on 20 July. Actually, the reason for Taliban to close, to pressurize the government, as well as telling Swedish committee that you are not doing enough to protect the sanctity of the health facilities. However, we turned that into an important advocacy agenda, and we came quite strong and with press releases condemning that attack by the Afghan National Security Forces and asking them to be accountable and also respect the international humanitarian law. So that was one of the incidents, but the learning out of that incident was that acceptance, transparency, and impartiality enables the humanitarian and development actors to work in those communities, and that leads that transparency and openness and working closely with the communities creates ownership among the communities. And as we have seen in that example, that the population of Wardak took that ownership and negotiated the reopening of the health facilities. When it comes to the COVID response related violence, we had noticed that there were examples where the armed opposition groups had been using the health facilities to conduct awareness-raising sessions related to COVID response inside health facilities, while not listening to the health facility staff that entering armed into a health facility and then conducting COVID-19 related awareness raising. So that is a kind of an attempt of instrumentalizing the health services and politicizing the health services, that the armed opposition groups show the communities that within this COVID outbreak, we have been acting, but by the expense of breaking the international humanitarian law and not respecting the sanctity of the health facility. And that has psychologically and mentally stressed the health facility when armed opposition groups are taking control of health facility and doing those awareness raising sessions. The other very recent example has been that in a crossfire between Taliban and the government forces, a mortar hits the COVID isolation center supported by Swedish committee in Wardak province. And that disrupts for some hours the service delivery in that isolation center. So as Christina also referred to, there has also been instances of violence from the communities towards the health workers. And when the outbreak started in Afghanistan, it started to hit Afghanistan, then unfortunately the first ones who were infected in great numbers, they were the health workers working in the hospitals. And one of the reasons for that was no sufficient protective measures and personal protection equipment provision to the health facilities by the government. And that had resulted to a large number of health personnel were infected with the coronavirus. And that has kind of given a sense to the communities. And sometimes when patients due to the lack of resources when the health personnel were not able to effectively deliver the services, and then the communities were committing violence against those staff in the health facility, while not necessarily seeing the resource constraints and the limitations of the health, and that has resulted in beating and intimidations by the communities. And also, there were health facility staffs and hospital staffs who were voicing for the government attention to the personal protection equipment, and then the government was pressurizing them that you guys should not be public and publicly talk. So to come to the concluding remarks, there had been violence from different parties, including community members, that has increased during COVID-19 response towards the health workers. But when it comes to the general effects of conflict on the health services delivery, we also have certain learning that working very closely with the communities and ensuring mutual trust and ownership, that is key in continued access to those difficult areas, even those areas that are controlled by the armed opposition groups. Thank you very much.
Thank you. That was really very enlightening and extremely complicated. We have some very interesting questions for all of you. I will start with a question I think Christina can take, although others as well. We know that during the Ebola response, there were hundreds of attacks on health workers and health facilities. Do we have any insights into how that compares to violence in connection with COVID? Are there similarities, differences? Do you have any sense of that, Christina? And as I said, the other speakers can also comment, but can you share your thoughts on that one?
Thank you, Len, and thanks for the person asking that question. I think the true answer we will probably only see in a few months from now. But at this stage, I think we really have to think about the differences of public health responses in conflict-affected areas and those in other communities, because I think there is a considerable difference. And I'm saying that partly because I'm comparing the Ebola response in the Eastern DRC with what we're currently seeing in Equateur in the same country, but an area in the DRC not quite, not affected by the same kind of conflict as the East. Where I think even within the same country, the Ebola response is playing out quite differently. So in short, what I would say is wherever we will see a COVID-19 response having to be implemented in a conflict-affected area, I think we will see very similar patterns, because the distrust in everyone in conflict-affected communities is extremely high. Whereas if we see COVID-19 pandemic measures being taken in communities that have other issues, I think we will see other issues coming to the forefront. So the bottom line I would really say is that it seems whatever violence emerges is very much the expression of the underlying problems that are already there, that just become a bit more extreme. So we will, so it will very much depend on the context, I think. That's my prediction anyway. So we'll see what we can say about it in a few months' time.
Thank you. Christian, do you want to address that as well? If not, I have another question for you. I ask you only because you worked on Ebola as well, but if not, I have another question for you. Do you want to address this one, or you?
Sure.
Go ahead then.
Yeah, the key point from what I've observed is government legitimacy. As long as you have a very legitimate government in place, the population is likely going to listen and have some level of confidence to the country leadership. But whenever the country leadership is in questions, like what we see here, the election upcoming and people being ready to go massively against the ruler, whatever suggestion that will come will be the reflect of that underlying situation, as Christina has said, people opposing to everything that will come from the government as guidance. In the armed conflicts area here, as I have seen, the problems are very different compared to the town, because any town, we have the coverage on social media being higher and the use of social media being higher than in the rural area. We see more violence linked or led, maybe, we don't know, by some group of people to inspire some opposition to what says the government versus to the rural area where there's no coverage of social media. On those areas, we will see maybe some other situation related to the presence of any dominant armed groups who like to either take advantage of the response or to ruin the effort on the event, on the response.
Thank you. You know, I have another question for you, but I want to turn to Khalid. At the end, you talked about community engagement, and we talk about that a lot in the context of prevention of violence. Could you, Khalid, talk about some of the strategies you use to engage communities as you discuss at the end of your presentation?
Yes, thank you, Len. The community engagement and acceptance should be looked at from a longer term perspective. What I mean from the longer term perspective is to ensure the community's engagement from the planning stage to the implementation and then to the follow-up. What I mean with the planning stage is to try to ensure continued dialogue and target group consultations at the start of any development or humanitarian response engagement. But very much Swedish Committee is a development organization and our programming is longer term programming, while due to the emergency, we also stepped into response to an emergency response. But the effective strategies are to work with those traditional structures present in the communities in the form of traditional shuras. And in Afghanistan, in many provinces, those traditional shuras, religious scholars, community influentials, they are members of those village level and district level shuras. So to engage with them closely and plan together with those village shuras creates a lot of ownership for those activities in those communities. And there are quite often instances of forced closures. And then it is those local and village level shuras who are taking the ownership and negotiating the access and reopening of those services. And also there are pressures on the health facilities, and these communities are also taking responsibility for the security of the health workers. Quite often in deep and remote rural areas, one of the challenges is lack of professional staff. And then those staff needs to be deployed from the other areas. And then that needs to be done in very close coordination with the local community so that they provide that security, accommodation, and all this support to those staff. And that has been quite successful in case of health service delivery. But the key is also to be as transparent as possible about the values, about the red lines, about the international humanitarian law. In the shorter term, due to lack of awareness on those communities level and on part of the armed opposition groups. Problems arise, but it pays out in the longer term, because then it facilitates the understanding, the longer term understanding, and creates that kind of support and acceptance on the part of all parties to the conflict and communities. That is also key to be transparent, open, and also very clear about the values, red lines, and also the and continuously raise awareness on the vision, mission, and values of who we are and why we are there.
Thank you. I want to turn back to Christian on that same question about community engagement, but there's a prior question that we have, which is that there are parts of Central African Republic where COVID has not really hit yet, but there have been lockdowns for many, many weeks. And people there in these communities that are in lockdown lose access to employment, to food, to going to church. And are those practices stirring resentment and violence, or are they accepting it? What is your insight? What insights can you give us about the effects of these lockdowns that are hurting people in terms of both violence and your outreach to the communities? Could you reflect on that? It's a tough question.
Yes, Dr. In Central African Republic, what we've seen, it's more Bangui, the capital city, and maybe a couple of towns near Bangui that were feeling the impact of the lockdown. In the rural area, people had much more to worry about, which is the permanent presence of armed groups. And again, these armed groups were totally ignorant of the call of the Secretary General on the ceasefire. They continue their business as usual. We got from December to now up to 2 big confrontations that happened with a number of people being displaced. So COVID or not COVID, it's business as usual. So people are concerned by the presence of the armed groups that they didn't even feel any of the lockdown impact. And again, because the government has very limited presence in those areas, the COVID restrictions were likely not really respected, or people didn't really care about, or they didn't even hear about. So survival was the main business for the people in the rural area. For your information, armed groups still control up to 70% of the country territory. So in Bangui, the lockdown has an impact as elsewhere, and the government ended up finally to consider relaxing some of the measure. Unfortunately, at the time where the curve is still going up. Why? Simply because it's become difficult for people to handle. People struggle to put food on the table by locking them down, and we know the level of poverty in our Central African region. Government is not subventioning or subsidizing those people to get some other alternative way of surviving. So it's reached a point where, to be realistic and honest with the people, you just advise them to maintain some social distancing, but please go out, do your business, and find the food for your kids and your family. So the relaxation measure occurred recently, and church went back reopening and bars, and unfortunately, the agreement was for them to respect the social distancing and the maximum of 15 people per church services, while for school, they're still figuring out how to adjust it. But the first day the church were reopened and everybody went in, and the mass was there praying and thanking God. Well, there is nothing we can do except hoping that contagious doesn't climb with the resume of these services. So to come back to the question, in rural area, people were not really concerned by COVID because they had the immediate threat, which is the presence of the armed group and the daily violence that they go through, that they didn't even feel restriction being imposed to them. Over.
Okay, thank you. We have just time for, I guess, one more question. It's a question for Christina. In the countries you've looked at, have there been reports of cyber attacks affecting healthcare?
I think I'll have to pass on that because I've not been monitoring. I don't know. Sorry, Simon, I don't know.
That's a satisfactory answer. So I'll ask one more question. If each of you just take a minute or so. We've talked about the government. We've talked about your role as health providers, as NGOs. And you've mentioned aspects of the conduct of the government. What role do you see the Ministry of Health playing or could play in ameliorating or limiting the violence where they may be at risk? So if you can just speak for like 1 minute on those questions, any of you who want to address that, that would be great.
I can start maybe. For Central African Republic, at the beginning of the outbreak, we quickly joined a couple of actors around the minister and start discussing the best way to get the community participants to the effort of controlling the outbreak. So it was really open and advised that I personally lead the Community Engagement Commission that was set up before being restructured and then given a shape. So what we did was to constantly collect the trend in the community of what was not going well and was raising more tension in the community, and structure those complaints and present to the minister and advise technically what we believe the health could do and other ministry as well could do. It was really open to that, and that's helped really controlling the problems. And at a very given moment, himself will address through a Q&A with journalists all the other issues that could give more confidence to what healthcare workers as well as humanitarian were trying to communicate with the community.
Thank you. And Khalid, do you have something to say on this in this last minute?
If I understood the question correctly, because the voice was breaking, as if I could grasp the question completely, it was the role of the ministries of public health in this situation.
Yes.
Okay, good.
Just very quickly, though, very quickly.
Yes. I believe the ministries, particularly the Ministry of Public Health in Afghanistan, they are playing their role to safeguard the health services from that instrumentalization by the military wing in the government and also armed opposition groups to try to uplift that impartiality. So the Ministry of Public Health in Afghanistan is doing quite good in that regard. But in general, in developing countries like Afghanistan, the COVID situation has really overstretched the already stretched capacity of the health infrastructure. And it will take time until that overburden on the health system is recovered. And also there is a lot of need for health system strengthening support once the COVID situation is over.
Sure. Well, we're at the end, and I want to thank all of you for your presentations and your insights from these very difficult situations, even before COVID, and we will keep working on this issue. And before we close, I want to turn this back to Paul Spiegel at the Center for Humanitarian Health to talk about what's coming up next.
Great. Thank you, everyone. And thank you, Christina, Christian, Ahmad, and Len. It was really, really interesting and also a very difficult situation. So next week will be our last webinar for this series. And we want to thank everyone who has been consistently watching these. And what we're planning to do is to have a lessons learned from our COVID-19 humanitarian.com website, where we have been uploading and interviewing many people from the field. So we will be discussing some of the key issues that we have found, and we look forward to a fruitful discussion. So thank you, everyone, and have a wonderful morning, afternoon, or evening.